And right now, we're gonna change to another presentation. Transition now to the broader landscape of surgical advancements. We are thrilled to welcome Dr. Chung-Wei, the Vice Superintendent of Shouchuan Memorial Hospital. Please. And Dr. Ling will shed the light on Taiwan's advancements and challenges in surgical education with a particular focus on minimally invasive and robotic surgery. So this really interesting topic. Thank you.
Thank you very much for the introduction, and it's my honor to be here to talk about the developments and the training of minimally invasive surgeries. And I'm a GP surgeon, and liver is one of the most difficult things in this surgery, so I will use this as the example of my talk today. I was trained in Veterans General Hospital back to 2000. So I graduated from my resident training in 2004. At that time, the only thing I can do is lab calling. And actually, my teacher don't allow us to do lab other things. So only thing is lab calling. But you can see 2004, only a few years later, 2007, the report of laparoscopic liver resection actually increasing. So we don't know it, and we cannot perform it. And all the factors regarding mortality, mobility, complications, blood loss, hospitals, everything, almost everything, laparoscope is better, even for liver. And 2015, 10 years before, there is already second international consensus of laparoscopic liver resection. That means already lots of discussions of lab liver. At that time, 10 years before, minor is standard, major is doable, but of course it should be reserved for expert surgeons. And adequate learning is very important because you have to learn how to do it. Then that is back to 2014. And you can see the blue bar, that is minor resection. Someone would say, oh, the report case is increasing, but most of them are still minor. So that means you can do lab liver resection, but only for small tumors, peripheral locations. But that is not true because 2014, we already published, I'm in the author list, we already published one international experience of lab liver. So that gives you less blood loss, less complications, also shorter hospital stays. So lab liver is also doable for major. But life is not so easy. Nowadays, we are doing some patients like this, repeated recurrence, treated by radiofrequency tests or sometimes radiations. So patients come to us like this. Lots of adhesions, previous surgeries. So actually doing surgery in redo case is very difficult. So can we do it by lab? Yes. It's 2021. We already published repeat liver resection. It's also doable using a laparoscope approach. So just last month, 2025 June, last month, we already held third international consensus conference. And interestingly, only 20 years developments, minimally invasive major probably will be endorsed as a standard care. And surprisingly, donor hepatectomy using minimally invasive approach also will be standard. That actually shocked me because donor hepatectomy, we always say donor safety, donor safety. Laparoscope or robotic approach is like a kind of dream. But this year, we already discussed about this. Probably donor hepatectomy will be standard of care. So nowadays, we can say minimally invasive approach for liver is a standard. But there are still some problems because not every surgeon can do it. Because instrument is different. Compared to open, we use our fingers and hand to do liver resection. But using the long instruments, it's totally different. And hemostasis is more difficult. And learning is a problem because it's more difficult to learn. So the problem is, will robots new technology will help us to do this kind of difficult operations? My answer would be yes, because 2020, we already published one robotic liver resection, and the conclusion is robot liver resection is safe for experienced surgeons. If you have experience, you can do it, and shortened outcome is comparable to lab to open. And the impact of robots nowadays, that gives you shortened outcome improve, and shorter operation time, lower complication rates, and shorter hospital stay. But of course, the cost is higher. And I will show you a little bit of the difference between laparoscope and robots. So the first thing you can see the stability of the camera, and of course that is 3D, because that is the real 3D camera. So when you sit behind the surgeon's console, you have the 3D, you are just like watching a 3D movie. That is very critical for the dissection. And also the endo-wrist instruments, that is the signature improvements of the instruments compared to conventional laparoscope. And in some critical scenario, for example, this one very commonly happen in liver resection. We have a bleeding, and we need to do sutures. But if you do laparoscope approach, suture will be very difficult. But using robotic platform, using the endo-wrist, it will be easier compared to laparoscope to do the sutures to stop the bleeding. That is very critical for the safety of the patients. And that is 2022. Just after the pandemic, we have a chance to cooperate with Intuitive Company. That is the biggest surgical robot company right now. And we have a workshop discuss about the liver resection. We try to detail in everything, including patient positioning, including the procedure, how to put them, and the instruments you should choose, and also the trocar placements. Then step by step, you can do the robotic liver resection. For example, this one is a very typical lap hepatectomy for tumor in segment 4A. So you can see using the robotic platform and using the endo-wrist instruments, we can almost, I would say almost standardize every step and every technique of the left hepatectomy. And this is also useful in the left liver procurement. So it's not very difficult. We took down the gallbladder and using the endo-wrist, open the laser augmentor here, and then encircle the hyaline. And then later on, we can do the Pringle maneuver during the parenchyma dissection. And then because this is anatomical left hepatectomy, we have to isolate left pedicle. So I open the capsule, and this is mobilization of the left hepatic artery, and later on, that is left portal vein. So after this, because the knowledge of the anatomy, we know this is left hepatic artery, and also behind it, we isolate the left portal vein here. And after occlusion of the inflow of left liver, then usually nowadays very standardized, we inject the ICG for the demarcation of right and left. So you can see the demarcation line. Now it's also already very clear, but ICG, I would say that is more beautiful to show you the demarcation between right and left. And then we can do a very precisely parenchyma dissection to do the left hepatectomy. And also this is for rights, a little bit different of the trocar setting. And you see these settings, we can do very formal right hepatectomy. So I will not repeat the video because of the time limits. Surgery now is in evolution. Why I say it? Because nowadays we have a 3D simulation of the software. So now the younger surgeons, now the students, they can have a more precise idea of the vessels, bile ducts, and the relationship between the vessels and also the tumors. This helps the HPP surgery a lot. And also nowadays we have pre-op surgical planning. So you can see we can set up the resection line, and then we can think about what I will face during the parenchyma transection. That is also very, very important. That is kind of like prepare yourself for the surgeries. And also volume, that is also very important for transplant and also for major hepatectomy, because functional liver remnant is very important to prevent the liver failure after liver resection. Nowadays, technology, we have the biggest one. This is Da Vinci system. And new machine is coming. This one, Medtronic, Hugo from Medtronic, is already in the market for 2 years. And we have more and more and more and more robot coming. So next week will be a Society of Robotic Surgery World Congress will be in France. So supposedly we will see probably more than 30, 40 new robots come to the markets. So it's the trend. So I'll introduce a little bit about our hospital and our training center, ERCAT. If you know ERCAT, actually it was established by Professor Morisco in 1994. And that is, at that time, that is the biggest one, the base one to learn how to do minimally invasive surgeries. And in Taiwan, 2008, we built up the first overseas branch of ERCAT in Asia, in central of Taiwan. And this is our auditorium. We operate more than 30 courses every year. And very often we have the lectures and also have the live demonstration of the surgery, because observation of the surgery is the most important part to learn how to do it. And also we have the lab to teach and to allow surgeons to practice on the models, including animals and also the cadavers. Nowadays, we have 10 centers all over the world, but of course, Taiwan is the only one as the first one in Asia. We operate almost everything from neurosurgery, from chest, esophagus, GS, liver, pancreas, hernia, urology, and also some orthopedic course. So we operate more than 30 courses every year. And this one is one of the examples. This is TR1. That means the basic level of the training. That is general surgery fundamental course. That is 3 days. We have the lectures. We also have the labs.
So this week has been really successful. We have the general surgery course.
And this is the very, very common
that is our signature
scenario
course.
of our training.
We cover almost everything of the GS.
It's good opportunity for not only the participant but the faculty like me. This course, bariatric surgery or TORE, is not so common in Japan. So I learned it on live demonstration.
Day one was more on suturing. They spent the whole
That
time
is
in the laboratory.
usually in the morning that is lecture. In the afternoon they have the chance to practice
on day three,
what they
they're
learn
now doing
in the morning.
procedures.
So in this kind of procedures, they're able to practice their laparoscopic suturing skills.
And
Where they
usually
can
we
apply
invite
them-
the faculties
apply
from
these skills
all over
into
the
their
world,
future
especially in
practice with their
Asia.
patients. This is the GS intensive course for
And
general
for this
surgery.
course, we usually
Day
use
3
pig.
already.
Sometimes, because of the anatomy, we have to use
And
cadaver.
this is the hands-on
And
exercises.
this guy is from Philippines.
We have our participants enjoying the
And
workshop.
also
They
professor
learn a
from
lot, they
Philippines.
perform.
And this is our year calendar. And in our center, we have 1 Da Vinci SI, 2 Da Vinci XI, only for training. That is very luxury because machine is not cheap. We already did more than 100 courses, trained 357 participants till now. And we also have one Hugo for training. And the surgeons come to our center, they have the experience, they have the chance to practice on different models of the robots. And we have also robotic week because you need to practice on the surgeon's console. So we have the robotic week for basic, you learn how to operate the machines, and also the advanced, you learn how to do the surgeries for different subspecialties, upper GI, low GI, colorectal, hepatobiliary, pancreas, liver, and also hernia. And we also took fellows, so it's very common in our OR. You can see the lady is from Slovenia, very far away from Asia, but she still come to us. And the surgeon right side, she is from Philippines, stay with us for 1 year. So we have a very friendly learning environment in our hospital. So allow me to quote John Dewey. You cannot teach today the same way you did yesterday to prepare students for tomorrow. So we have to teach in a fashion way of the surgery. Thank you very much.